Good day. I am Donna Elliott, Quill Healthcare Consultant, and I would like to introduce my former colleague and UHC Director, Ms. Regina Vasquez. Between us, we have 30 years of healthcare payer contracts analysis and negotiation experience, and have negotiated over 10,000 payer contracts. I am pleased today to welcome you to Quill's first 2016 value-added webinar for practices. Quill Healthcare is the leading seller of medical supplies and office products and is dedicated to providing you with useful content in these webinars as a value add to your practice. Today's topic, 10 Best Payer Contracting Practices for 2016, is presented by Ms. Regina Vasquez, and I am pleased to have a special guest speaker with us today, Mr. Stanley Nachimson, a well-known author and expert in the use of standards and technology in healthcare, and an advisor to a key ICD-10 software vendor, ICD Logic. If you lose the web session today, go to joinme/healthsense. This will restore your web session. After this session or later, go to healthsense.com/copies to get a PDF copy. Today, I'd like to take the opportunity to introduce Ms. Regina Vasquez, the Director of Ancillary Contracting for the Mountain States and Pacific Northwest at United Healthcare. She has been in the business of contracts negotiation between medical providers and insurance carriers and fee schedule analytics for over 10 years. Additionally, she has over 15 years of small business operation and project management experience, plus 5 years working as an ancillary professional in the postpartum unit of a large private hospital in San Diego County, California. She has a proven track record of success in organizational development, operations, and management, including workflow management and customer service. Regina is on the Economic Development Commission for the town in which she lives and on the boards of 2 not-for-profit groups focused on providing opportunity for young people to participate in competitive sports and music activities. I'd also like to take the opportunity to introduce Mr. Stanley Nachimson, the principal of Nachimson Advisors, a health IT firm dedicated to finding innovative uses for health information technology and encouraging its adoption. Focusing on assisting healthcare providers, vendors, and planners with their ICD-10 and regulatory implementations, its impact on clinical documentation, and providing advice for HIT industry status and trends. He is also the author of an authoritative paper on the cost of ICD-10 for physician practices. Stanley served for over 30 years in the U.S. Department of Health and Human Services in a variety of management positions, developing HIPAA policy, regulations, implementation planning and monitoring, personal health records, and serving as a liaison with several industry organizations, including WEDI and HITSP. He brings a wealth of experience to the use of standards and technology in healthcare.
Thank you, Donna, and thanks to all of you for joining us today. There are 2 sides to revenue management, the operational side and the informational side. The operational side includes technology and business processes that manage workflow. The informational side consists of payer contracts, which may be a driver of care delivery behaviors based on the analysis of utilization and reimbursement. Network participation with payer organizations are generally the primary source of reimbursement for medical care services for the majority of practices. As such, it's important to develop a good working relationship with the network management representatives in the payer organizations who cover your practice's patient population. Later in today's program, Stanley will discuss coding, which is operationally one of the most important drivers of revenue for practices. Today's learning objectives are to, when we finish today's program, you should be able to prepare a SWOT analysis to identify opportunities and threats to your practice's reimbursements, evaluate your current reimbursements, review your billed charges, know techniques for negotiating win-win agreements with managed care companies. You'll learn a simple technique for monitoring claims payments and comparing to your contracted rates to ensure that you're paid correctly. And we're going to just briefly discuss ACOs, what they are, and how you can bring value in an integrated delivery system. Let's dive in. Payer contracting is a process with three basic components or phases: preparation, negotiation, and contract performance monitoring. Hopefully that won't be the case for you. Contract negotiation process is a cyclical process, and this flow chart provides a breakdown of activities in each phase, beginning in phase 1 with analytics of contract performance and developing a proposal that is delivered to the payer network contracting team. Phase 2 is the back and forth of negotiation until an agreement is reached. And phase 3 is the monitoring of contract performance. As I mentioned a moment ago, you can see that this cycle repeats, and practices often review and renegotiate their contracts at the end of each contract term. Within the three phases of contract negotiations, the flow of activities include the following 10 best practices. Best practice 1 is to evaluate your top codes and figure out which ones are driving revenue. 2, benchmark against Medicare and other payers with which you have contracts to identify areas where you may be under-reimbursed compared to your market. It's common to use the 20-80 rule, which means you're looking at the top 20 codes that represent 80% of the revenue to your practice. Practice 3, conduct a SWOT analysis for your payer fee schedules and look for opportunities to increase reimbursement for services that are not reimbursed at market competitive rates, and then assess your charge master. Practice 4, looking at a SWOT analysis or conducting a SWOT analysis for your practice. And practice 5, preparing an impactful proposal letter. Practice 6, under the negotiation phase, is to deliver your proposal to the appropriate network manager, do some initial follow-up, and establish rapport. Practice 7, follow up frequently and keep the payer representative engaged. Respond quickly to any requests that are made for additional information and to any proposals that you receive from the payer. Practice 8, evaluate payer proposals and look for ways to optimize counteroffers. And it is a good idea to not take the first no if you get an answer, if you get that as an answer from a payer representative. But I would ask that you use or recommend that you use escalation to senior management judiciously. Best practice 9, review your contracts for language that could affect your reimbursement. Best practice 10, once you've got an agreement in place, is to monitor your payments, identify reimbursement issues quickly, and work closely with your payer representatives to resolve any payment issues as quickly as possible. Now let's look at each of these best practices in a little greater detail. Best practices 1 and 2 are part of your SWOT analysis. So for those of you who may not know, SWOT stands for strengths, weaknesses, opportunities, and threats. A common practice when preparing for negotiations is to do a SWOT assessment, your business practices, and your business environment. The SWOT analysis of your reimbursements includes best practices 1 and 2 and 3. Best practice 1 and 2 are benchmarking and reviewing your current reimbursement. It is a common practice to use Medicare rates as a basis for comparison, and you can also look at the rates from other payers you are contracted with. This will help inform how you approach the negotiation depending on the outcome of your analysis. The SWOT analysis also includes best practice 3, and in this part of your analysis, you will review your billed charges against your payer rates. This is an important practice because most contracts include lesser of language that states that the reimbursement for any service will be the lesser of your billed charge or a percentage of your billed charge or the contract rate. So if you're billing less than your contract rate, you will only be paid your billed charge. which means you're contributing to under reimbursement. In addition to reviewing your current reimbursement, the SWOT analysis will include a review of your business operations and your business environment. Ask yourself, what makes your practice or service a good quote-unquote partner for the payer? How does your practice address key payer concerns of access, quality, and cost? Relative to market needs, think in terms of what your practice does very well and what is useful in satisfying the needs of customers and patients. And you may want to look for opportunities to participate in population health management programs, such as accountable care organizations. Before I continue on to the next best practices, I will pause for a few minutes to see if there are any questions on these first four. So I'm going to put the question and answer mode on. And Donna, if you could share with everyone how to unmute their phone.
In order to unmute your phone, press *6, and then to remute it, press *6 again.
Have any questions come into the info@HealthSense?
We've had a couple.
Okay.
The first of which is, how do you find your provider advocate or network manager if they don't know who they are?
That is a very good question. Ideally, they would be reaching out to you periodically, or you would have an ongoing relationship with them. Very important, in my opinion, to develop a good relationship with your network management team and your provider advocate so that as issues come up throughout the term of your agreement, you can have a person to go to, someone to touch base with, someone to communicate with who you know can see an issue through to the end, to a resolution. But if you don't know who that person is, you can contact the provider services line and tell them that you need to speak directly with your network manager. You can search social media resources such as LinkedIn and contact them that way. You could look at who signed your contract. Usually it's a VP level of network management, VP level of the network management team or higher. You could get in touch with that person's office through the main number or go through provider services. It's a good question.
Thanks, Regina. One more question. You mentioned ACOs. This particular individual thought that they were mostly a Medicare phenomena and questions whether or not they're prevalent in the commercial industry arena as well.
Another good question. Yes, Medicare was the initial driver of ACOs. As a result of the passing of the Affordable Care Act, Medicare established accountable care organizations and the shared savings model for reimbursement. We're going to, a little bit later in the program, get into the details of ACO structure. Basically, though, it's a group of providers that agree to take some level of financial risk for the medical care of a population of patients that's assigned or attributed to that group. Commercial payers are rapidly expanding this model to commercial populations, particularly in the HMO managed care space. And among large employer groups, there's an interest because of the focused care coordination, patient engagement, and preventative medicine, which can create savings in the overall cost of health care for their employees. Another very good question.
Thank you.
So could you repeat the email address again for people who have questions, Donna?
The information is question@healthsense.com. That's question@healthsense.com.
Okay, we'll keep moving forward. So once you've completed your SWOT analysis, you'll want to put together an impactful proposal letter. And you'll look to building your proposal letter with a focus on accomplishing a gain-gain outcome. Some people say win-win. I use the term gain-gain simply because when you say win-win, that implies that maybe somebody lost. When there's a winner, there's usually a loser. So with gain-gain, both parties come out having gained something, which is really the ultimate goal. The proposal basically has three sections. The introduction, where you build on the rapport that you've established with your network representatives over the course of your dealing with them. You identify the key value that your practice brings to the members and to the network. And then, of course, you're going to include your proposal. The next few slides that we're going to look at give examples of components of a well-built proposal letter. So the first piece, as I mentioned, you're going to establish your relationship or reinforce your relationship with the payer. You'll state the reason that you're contacting them, and then remind them of the volume that your practice or services provide, volume of members that you serve, the contribution that you make to providing care to the payer's membership. And below here at the bottom of this slide, you can see an example of an opening paragraph, and I'll just give you a moment to look that over. So the next section of your letter, you would incorporate what makes you a good partner. Highlight your service area, your specialties, unique services, clinical and administrative efficiencies that make your practice or services a good quote-unquote partner in the payer network. And you'll hear me use the term partner a lot. It's not in a legal sense, of course, but as someone who works arm in arm with the payer to provide good medical care to their members. At the end of your letter, you will restate the purpose, of course, kind of wrap things up, and then close the deal, so to speak, by including your proposal. And at that point, too, it's a good idea to give the payer representative a timeline that you're looking to meet, right? So this will make sure that the negotiation stays on track time-wise. Most contracts will tie renewal periods to anniversary dates, so you want to be very cognizant of when you notify the payer. Go to them, with plenty of time to give you to meet your requirements under the notification for the notification requirements under the contract, but also to give you time to go back and forth with the payer so that it's not rushed and you have time and you can be thoughtful about your approach. So once your proposal letter is prepared and you're ready to roll, you want to deliver that proposal letter to the appropriate network manager. And again, if you don't know who it is, go back and do a little bit of homework. If you can avoid sending to a mailbox from a provider perspective, that's probably preferred. You do want to put this in the hands of somebody who can actually take action on it. And that's, again, why it's a good idea to establish and maintain a relationship with your network management team at each payer organization. And then under Best Practice 7, you'll want to follow up frequently and keep the payer representative engaged. Again, respond very quickly to any requests that they make for additional information and to any proposals that you receive from the payer. Best Practice 8 is when you get a proposal, evaluate and look for ways, to again, find that gain so that you each walk away having gained something from the negotiation. And if you get shut down, if your frontline payer representative is not responsive, or you're hearing no, and you've got a good value proposition, that there are issues administratively with your contract, that there are things that could be improved upon, even if it's other than higher rates across the board, it would be appropriate at that point to maybe escalate to a director level or higher if needed. Generally, director levels can get the job done. But you'll want to use that judiciously and make sure that your frontline negotiator helps you in that process, that escalation process, because the frontline negotiators typically won't. They're conferring with their management teams throughout the process. So it's good unless absolutely necessary to bring them along and have them facilitate the discussions. Best practice 9 is taking a good look at your contract language. Once you get it, you want to understand what your responsibilities are under the contract. I mentioned earlier notification requirements, and this isn't always tied to renewals and renegotiations, but sometimes that notification window can be used as part of the negotiation. They look at that renewal term as a window for negotiation as well. Understand what your timely filing requirements are, how you might get paid for non-covered services, and understand your pre-authorization requirements. Sometimes certain services are required to get pre-authorization before you provide the service. So it's very important to know what those are and to request or look at the provider manuals, which are usually available through the provider portal on a payer website. Those provider manuals are referenced in the contract, and they include administrative policies and practices as well as medical policies and payment procedures, that type of thing. After your new agreement terms become effective, you'll want to monitor your claims to be sure that they're paying at the correct allowed amounts. So basically, you'll look at your contract allowed rate, and you'll compare that when you get your EOBs back to what's being allowed on your noted as being allowed on your EOBs. And if you see any discrepancy, you want to bring that to the attention of your network account manager or provider relations provider advocate as quickly as possible, so that you can get those issues resolved very quickly before you have a huge backlog of under or incorrectly paid claims. So this is just a demonstration. If you see the negative, if you're getting paid less than you should be, you want to, again, bring that to the attention of your advocate or your provider relations team as quickly as possible. So before I pass the ball to Stanley, let me touch on some opportunities that exist in ACOs briefly. We had a good question about ACOs, and they do represent an opportunity in the market to leverage your best practices and leverage your practice to optimize revenue. For those who are not familiar, ACOs are clinically integrated organizations who agree to manage a population of patients and who carry some level of financial risk for that care. Usually, ACOs are primary care centric, meaning that the organization is built around the primary care providers who are on the front lines of providing care to the population of patients and who oversee care coordination when specialists and other services are needed. There are basically 3 structures for ACOs. The first model, you'll see 3 kind of independent groups. The PCP group would be on the front lines, as I mentioned earlier. They would have groups of specialists who support them, and then they're all tied or they have a connection with a hospital. The second model are multi-specialty groups with a significant primary care population of doctors who are also tied to a hospital care organization. And then the third model is the fully integrated, vertically integrated physician hospital organization or hospital with medical staff on board. So all 3 of these models are employed right now in the ACO space, and it really just depends on what the payer's needs and the population of providers in the area as to which one you might run into. Another trend in contracting is value-based contracting model. This is a model where certain quality and or utilization benchmarks and targets are established, and some financial incentive is offered for meeting the targets in a given time period. The sample here is from a large commercial payer in the southeastern U.S., and you can see the incentives are focused around a quantitative and qualitative scorecard for the delivery of care practices. So usually what happens in these value-based contracting models is increases are given or based on making an improvement of an agreed amount in each category. In most cases, the total increase is split among categories, where a certain percentage of the agreed total increase is divided between the different categories, which is good, from the provider perspective, I can see that being a positive because it's not an all or nothing. And there may or may not be a penalty if the benchmarks are not met, meaning that it's a carrot or stick kind of argument, kind of a presentation. They give the provider the carrot of improving quality or improving on the spend, on the cost of care, by giving, offering increases, or if they don't meet those benchmarks, they could be penalized in some way. More often, I've seen, both in my current work and in, work as a consultant before I came on, that the carrot methodology is the preferred methodology, meaning they don't get penalized if they don't meet the benchmarks, they just don't get their increases, the providers who sign up. So I'm going to wrap up this section by touching on trends in the healthcare market. The top trend overall is a movement from fee-for-service or quantity-driven healthcare delivery and reimbursement to outcome or quality-driven delivery and reimbursement. This movement is driving the increase in ACO organizations and value-based contracting by both public and commercial payer organizations. Because of the continued focus on lowering the overall cost of care and increasing quality, there is a greater focus on limiting or eliminating, reducing utilization of non-participating providers. And some contracts may include a reimbursement penalty when non-participating providers are utilized in a facility setting. For example, if an ambulatory surgery center utilizes non-participating anesthesiologists, they may have their payments reduced under the contract with a payer. Medicare, under bundled payments, Medicare is just rolling out a bundled payment methodology for mandate. I think it's a mandate for joint replacements in early April. Though there was a bill introduced to delay the implementation of that innovation initiative in order to allow for providers to continue to work through coordination and payment issues, the model mandated by CMS requires planning and coordination among providers, facilities, and post-surgery care providers such as skilled nursing and physical therapy, and then requires the complete IT infrastructure to support the episode of care. Commercial payers will be watching the outcome of that Medicare pilot closely, and there is an eye on establishing a bundled payment mechanism, particularly for total joint replacement and other high-cost orthopedic episodes. At least initially, that's where the trend is. It's expected that ACO numbers, both Medicare ACOs and private commercial ACOs, are expected to continue to rise, and mergers and acquisitions may accelerate as practices consolidate to take advantage of shared savings and value-based contracting opportunities. It's expected that going forward, there's going to be a leveraging of technology to increase access to medical care in rural areas and reduce utilization of high-cost healthcare settings. Telemedicine is gaining traction both from a consumer demand perspective and a cost containment perspective. Some payers are already providing virtual visits, which gives after-hours access to nurses and doctors and provides an alternative to urgent care and emergency room visits when medically appropriate. So to recap, contract negotiations occur in 3 basic phases, which include 10 best practices. Evaluate your top codes and figure out which ones are driving revenue. Benchmark against Medicare and other payers with which you have contracts to identify areas where you might be under-reimbursed. Utilizing the 20/80 rule, again, that's the top 20 codes representing 80% of your revenue. Do a SWOT analysis of your payer fee schedules and look for opportunities to increase reimbursement for services that are not reimbursed at market competitive rates, and assess your charge master to make sure that you're not billing less than your payer allowable. Conduct a SWOT analysis for your practice. Prepare an impactful proposal letter. Deliver your proposal letter to the appropriate network manager and do initial follow-up to establish rapport. I would encourage you again to maintain a good relationship, a good working relationship with your network management team and or provider services team at each of the payers with whom you're contracted. Follow up frequently to keep the payer representative engaged. Respond quickly to any requests that they make for additional information and to any proposals that you receive from the payer. Evaluate your proposals and look for ways to optimize counteroffers. Don't take the first no, and use escalation to senior management judiciously. Once you've established a new agreement, review your contract for language that could affect your reimbursement. Monitor your payments and identify reimbursement issues quickly, and work closely with your payer representatives to resolve any payment issues or administrative issues as quickly as possible. So before I hand the baton to Stanley, Donna, do we have any questions coming through the email or chat line?
We do. Again, *6 in order to unmute your phone and to ask a question. And then we have a question regarding obstacles with payers.
I'm sorry, go ahead and just repeat that.
*6 to remute your phone after you've asked your question. So the question we have, one of the questions we have online is, what are your suggestions for getting past the prevalent response from customer service or provider relations representatives that state our network is closed when requesting an opportunity to contract?
That's kind of a tough one, but it's a good question. Narrow networks are, I guess I'm referring, I would guess that you're in a situation where the payer may have a narrow network or they have a full network. So in the case of narrow networks, they're sometimes used to provide access at reduced cost to the insured's members, or in some cases, a large employer group may want specific access to specific providers for their employees. Again, it's usually to ensure a high standard of quality at reduced cost to their employees. So in either case, whether it's a situation where they have the payer has long-term relationships or they're narrowing a network, focusing on your value proposition and what makes your practice or services a good potential quote-unquote partner to serve the covered population, maintaining a good relationship with your network management teams at each payer organization, and then keeping your ear to the ground for requests for proposals from payers who might be looking to capitate services for a given population. That's becoming, I won't say popular, but it is a strategy sometimes that payers will employ to manage a patient population. So all of those are strategies that you can use to help get into a network where it might otherwise be closed.
Thanks, Regina. Another question about ACOs is whether or not DME providers can participate.
Well, that's a good question. So DME, I don't think we explained this earlier. So DME, for those of you who don't know, is durable medical equipment. In my experience, they often support ACOs. Sometimes, depending on the relationship of the ACO with the sponsoring payer, the DME may have a direct contract with the ACO to provide any kind of DME items like walkers or canes or, whatever, wheelchairs, that kind of CPAP machines, that kind of thing that members may need. Or in some cases, the payer has an agreement with the DME company that the ACO is required to utilize. It really boils down to how the contract is written and who carries the risk for that service in the division of financial responsibility for the ACO and between the ACO and the payer.
Thanks so much, Regina.
Okay, are there any other questions? Going once? Going twice? Okay, then, Stanley, you are up.
Well, thank you very much, Regina. Terrific guidance for our listeners.
I'm sorry, Stanley. Before you get started, let me just put us back into presentation mode.
Oh, okay.
There you go.
Thank you very much. And again, I'll repeat because it was absolutely true. Wonderful guidance, Regina, for our listeners, for the practices out there. And I want to build on a couple of your best practices to help explain how to make sure that some of the tasks, in fact, all of the tasks involved in the contract negotiation are as complete and accurate as possible. We talked a lot about in the beginning the data analysis, looking at your information, your codes, in assisting you in preparing your proposal letter. The key here is that the codes that you will be using on your claims should be as accurate as possible, especially as we moved to ICD-10 and some of the enhanced payer edits. It's critical that the ICD-10 code be specific, accurate, and complete. And in order for your codes to be specific, accurate, and complete, your clinical documentation must give you and contain all the information to make those codes complete. So one of the things that I have been focusing on as we move, but not only from ICD-9 to ICD-10, but now in the world of quality and quality measures, is advising providers that the documentation in their records must contain all the information that they need to show the patient's condition and all of the procedures that they have performed on the patient. Things like comorbidities, existing conditions, and things like that are often taken into account in either paying claims, in looking at the level of payment, and as to whether or not to pay the claim itself. Also, in terms of quality measures, they are often used to compute the quality measures and determine whether or not a provider reaches the appropriate quality measure and gets that bonus, or sometimes in the Medicare world does not get a bonus and in fact gets a reduction in payment. As we move forward with some of the Medicare proposals in the future, providers will be getting either bonuses or reductions in payment. Some will get bonuses, some will get reductions, some will stay at the same level as the fee schedule, but depending on their quality measures as well as some of their resource measures. So it is absolutely critical that when you present information to a health plan, you have the correct information, that accurate data coming from very specific clinical documentation and coding. There are several tools to allow providers to get to the right documentation. As we moved from 9 to 10, there were several companies, one that I am associated with, which is a Quill partner, a company called ICD Logic has a product called Cipher, which assists providers in getting to the specific documentation that's necessary to support an ICD-10 code and then the appropriate CPT code. What this does is make sure that a provider is reimbursed correctly and appropriately. So at least in your past data analysis, you are getting all of the reimbursement that you believe you are due, and you can present it to the payer and give them an accurate picture of what your reimbursement rates should be. Now, on the right side of this particular document, when you look at the monitoring your claims and documentation to allow you to perhaps renegotiate, again, what's important here is the accurate representation of what's going on in your practice. Are you completely, specifically, and accurately describing the patients that you're seeing, especially in terms of the severity of their conditions and their comorbidities? Are you putting down in your documentation all of the things all the procedures that you're performing, so you can bill for them and make sure you get reimbursed for them. One of the key things that you'll have in dealing with health plans now in the future is the audit process. And even if you've successfully negotiated a good contract, if the payer comes back at some time later and says, let me look at your documentation to make sure your coding is correct, if you don't have the documentation to support that coding, you run the risk of some very significant revenue loss and losing the ability to negotiate a good contract in the future. So the things to focus on really are, one, accurate, complete, and specific documentation. Secondly, accurate, specific, and complete coding so that you have the necessary data to go ahead and first present a good case to the plan, and then as you're monitoring, making sure you continue to get paid appropriately. Again, there are automated tools. Regina mentioned the fact that we are moving towards more and more automation. Providers should be looking at ways to assist them in the appropriate and the accurate documentation so they can get to the right codes. Regina, I'll just send it back to you.
Thank you, Stanley. Donna, do we have any questions at all from the audience, the listeners?
Actually, I do. Thanks for asking, Regina. This provider is an ambulance provider, and they're being told that their claims have to include a diagnosis code. Due to the nature of the model of how they provide service, they don't know what that code is, and not having seen the patient and not being the physician, can you provide some insight as to how to navigate this requirement?
Okay. Stanley, do you have any idea or any insights on the requirement for diagnosis codes for ambulance providers?
My understanding is that much like any other standard claim to a health plan, they will have to put in at least some sort of a diagnosis code that helps explain why the patient might need an ambulance. I mean, there are a number of diagnosis codes that relate to either patient weights or certain patient conditions, and that would match the ability to use the ambulance. I think the concern here is justifying whether or not the patient really needs an ambulance. There should be some sort of an observed diagnosis, perhaps a higher level diagnosis that can be placed on the claim. The ICD-10 code set does contain, things like whether the patient's short of breath or if there's an apparent heart attack or things like that. But I would believe that all ambulance claims will need, if you are submitting them to a health plan, will need particular diagnoses to justify the ambulance ride.
That's interesting.
Thank you so much.
Does that also apply to Medicare, for example? I mean, is that a Medicare requirement? Do you know?
I believe it is.
Okay. I was not aware. Thank you for that. Anything else, Donna, coming through the question line?
That covers the questions that have come through the question line. Thanks for asking.
And I did notice that there were a couple of chat questions that came up on the bottom of my screen, at least, during some of the discussions. I don't know if you've captured them, or it looked like there were a couple of questions that perhaps we can respond to.
Let me look at the, oops, sorry, I went back. Let me see if I can. Some
had to do with getting the Medicare fee schedules, and perhaps also seeing if you can get the factors or the average fees in particular areas, if you had any advice on how to get those.
Sure. Let's see what we've got here. Outside of CMS rates, finding competitor charge master rates. Let's see. So let me just really quickly run down here the chat questions. Yes, for Fran, you can get a copy of the presentation. Donna, will you let me go back to that screen here for everyone? I have to reduce that again. To get a copy of the presentation, you'll go to healthsense.com/copies. healthsense.com/copies. And then you'll be able to request a copy of the presentation there. Quill will also publish the video of this conference at some point in time, and I believe all participants are going to get a notification of where that is posted. Outside of CMS rates, finding competitor charge master rates. So Liz, you made that comment. Okay, so Liz, you made two comments. Best practice to gain access to industry rates in your area to complete an analysis of your charge master. That's a very good question. Stanley, do you have any thoughts on that?
No, I don't. That's outside of my area.
Outside of your purview. How about you, Donna?
Actually, Regina, that's something that HealthSense may be able to assist with. And we'll be talking about how you can have a practice analysis a little later on in the presentation.
Okay. Very good. We'll cover that then. And outside of Medicare, finding competitor charge master rates. So again, I think what I heard Donna say was that there will be an offer of contract review by HealthSense at the end of the presentation. Okay, I believe that was all of the chat questions, unless someone's writing right now. Nope, it looked like there might be somebody writing something. Okay. So, to wrap up here, just go to my show. So this is the recap for Stanley's comments. Stanley, do you want to run through this again real quick?
Oh, sure. Again, we are moving as an industry from pay for quantity to pay for quality. Much of our reimbursement will be heavily impacted by the quality of the work that we perform through some of the quality measures that continue to evolve. So in order to get the best reimbursement that we can, we've got to make sure that we are meeting all of the quality measures that the payers are evaluating us on. And those quality measures will be based on the coding patterns, patient outcomes, and the documentation that we have in our records. So that patient record that you keep that contains all of the patient's demographic characteristics and all of the documentation must continue to be as complete, specific, and accurate as you can possibly make it. Not only for the direct coding, but also for the quality measures and other items that health plans will be looking at. You've got to, again, focus on the clinical documentation. Whether it's the particular questions that you ask. Sometimes your electronic health record may assist you in some clinical documentation guidance, but it's absolutely critical that you look at the way that you are collecting information on patients and improve the information that you're getting. As this continues to occur, the emphasis on the strict CPT reimbursement, that is, the fee schedule just based on a CPT code, is going to shift. The fee schedules will be set using combinations of diagnoses and procedures, but also will be adjusted based on quality measures. Now, I think what's going to happen as we move and the continuing pressure on costs in the healthcare industry is there's going to be a need to focus on seeing the right patients, as many patients, and having as complete documentation as possible. It will be important to focus on your productivity because you will have these additional, we'll call them burdens, of more patient documentation and more administrative loads like computing and submitting quality measures. It is absolutely critical that you look to automate some of these processes that can be automated and make sure your practice continues to move forward, that you continue to educate yourselves on the change in reimbursement and new ways that health plans will be reimbursing you and have an ability to adjust to them as we move forward. I just finished a session with some of the practice management system vendors, giving them the same message. We need to help provider practices understand their quality, their coding and documentation, their patient population factors, and how they need to adjust all that information to make sure they continue to get paid accurately and to the greatest extent.
Right on. Just out of curiosity, and this is just something that popped into my head when you started talking about electronic health records. Do you see any trends in the consumer market about portable health records where patients carry their own records around with them electronically? Have you seen any of that?
There are a couple of tools that allow that. That has been sort of almost a holy grail for several years. I have to tell you, 10 to 12 years ago, when I worked at CMS, we did a pilot on personal health records. And what seems to happen is that very difficult for individuals to manage. It takes a lot of work to do that. And frankly, it became too burdensome for people to keep those up. They continue to rely on providers. I think what we're going to see is not so much individuals creating their own and maintaining their own personal health records, but either gatekeepers, ACOs, and others using the increased amount of interoperability among electronic health records to build that overall patient record. I think some of the I'll call them the millennials that are much better at iPhones and iPads than I am may grab onto some of those apps and try and do that. But I think it's still very difficult for patients to collect the information and collect all of the right information to enable them to have a complete record. And the flip side of that is, if I write down all my information and I give it to the doctor, there's some question about, how good was I at collecting that information, and how much can the doctor trust the information that I put in versus what another provider might have put into my record.
Right. Yeah, reliability of the information, sure. And I always thought too about the compatibility of a personal electronic record with a established, EHR. Do they plug in? Do they have to print everything and scan it in? I mean, I see where there might be burden there too.
Oh, absolutely.
But it's an interesting concept.
Yes.
Yeah. Okay. I think that brings us to the end. So, Donna, if you'd like to wrap us up.
Yes, thank you. Thanks so much to our speakers, Regina Vasquez and Stanley Nachimson. Wanted to take the opportunity to thank, again, Quill Healthcare for bringing this webinar to us today. For your contract assessment, you can contact Susan Charkin at 831-455-2695 or email her at charkin@healthsense.com. This half-an-hour high-value assessment is included as a part of this session. If possible, but not required, we recommend that you bring a revenue collected over a period of 1 year for each payer, your overall percentage of Medicare that you're currently contracted with for each payer, any known issues with each payer, such as collections, and any knowledge you have about your competition in the market that you are in. Susan will be pleased to discuss the approaches to moving each of your agreements forward to higher reimbursement and or other recommendations. And again, thanks to Quill for presenting this webinar. We are offering a $20 off when you spend $150 or more for practice supplies using the one-time code of QV3DLR84. Again, Quill is the leading supplier of office supply and medical supply products and hosts these meetings as a value add to their customers and prospective customers.